of the PowerPoint is to kind of supplement some of the things you've already heard. To go back and if you don't understand something, you can kind of fill it in. Or if you don't remember what, like we're going to go through the review systems. I'm not going to go through all of those, but so we emphasize when you have patients with an HENT, those are some of the review systems you're going to ask them. Okay, so I put them on the slides just so you kind of have that. I want you to know how to do a physical exam on HENT. Okay, I'm not oral, so someone else can teach that. But I want you to know how to do the exam, why you're doing this exam, and that's our goal here. So we're going to go through a little bit of a lecture, and then we're going to practice. I want you to know how to use the equipment. So the pan, we've got one here, the ophthalmoscope, the otoscope, how to turn it on. There's nothing worse than, you know, picking this up and going, I won't look in your ear, but I don't know how to turn it on. So why do we have a tuning fork? What are we looking for? So let's go through this. So here's your review systems. You know, we talked about these things. This is how we test. Okay, this is how we see patients. So there's two things we're trying. One, we want to see your confidence. So we make test questions out of review systems. You're going to see these, right? We're going to have the patients with these classic positives or negatives. So someone with pain in their eye, okay, blurred vision, double vision. That helps you get to a diagnosis. Those things I talked about. You also ask patients to try to come to a diagnosis or try to help eliminate a diagnosis. And then your physical exam helps you confirm it. This is, you can't see it, so I just gave you, that's what's on your sheet. It's everything that's on your sheet. So as you practice, you go each step down. Okay. So the head, Shelley went through this, right? We talked about the head, right? My computer. Yeah, it's quick. It's a general. I'm looking at your head. I'm going to kind of inspect it. I'm going to kind of palpate it a little bit. So you're looking for symmetry. Oh, I'm looking for things that are a little bit off. Do you have lesions that I'm going to pick up on? Do the ears sit where they're supposed to? If you look at your neighbor, okay, the ears should not sit a lot below your eyes. So if you draw the line here, your ears should sit a little bit above your eyes. If they sit below it, there's usually some type of genetic MR problem. So that's a dysmorphic. So if your neighbor has low set ears, you may need to reassess. Or there could be, they went through some trauma, you know. So those are things you kind of want to look for. The eyes, if you notice, fetal alcohol babies, their eyes are wide set. So measurement-wise is your eyes should not be farther apart than the width of your eye. So if I can stick another eye in between there, your eyes are too far apart. Okay. So the temporomandibular joint, so TMJ, this is a diagnosis of history and physical. So you hear it, you talk to the patient. But if you palpate over that joint, it's a lot of times tender. You're feeling for crepitus. Okay? As they move it, it pops and crackles. Now, if I don't have a complaint, people's jaw can pop and crack. And it doesn't mean they have TMJ. They just have a jaw that pops and cracks. Right? Right. Okay. There we go. And a lot of people have that. But it doesn't mean they have temporomandibular dysfunction, joint dysfunction. But if they have a complaint, you have to move the jaw side to side, up and down, up and forward, and back. Okay? Nose and sinus. So one of the things about the nose is you want to know about the discharge. Okay? Sinusitis is usually pretty classic with a bloody discharge. Okay? Someone comes in with a nosebleed, you want to know how much it's bleeding, how often, how long it takes to stop it.
So we all get a little bit of a nosebleed, especially in the winter, because of this dry out, or heater's on and it dries the air. But when people come in for a nosebleed that can't stop after 10 minutes, that's significant, okay? Or if they have bleeding disorders, okay? Someone who comes in with a smell from their nose, okay? My kid has a smell, it's coming from their nose. They have something in their nose that they stuck up there, and it's been there, and it's just pretty much rotted. And I'm telling you, it happens. So mom will be like, they have a sinus problem. It stinks out of their nose. It's gross. And it's a sponge, it's a bead, it's a bean, they've stuck million. So any smell, bad smell from the nose, think foreign body. Okay, those are kind of some of the things you talk about: discharge, bleeding, sinus pain. So when we get a sinus infection, it hurts. We get teeth pain, hurts when you lean forward because that pressure on the sinus cavity. Okay, so you guys know this: anatomy, maxillary, ethmoid, frontal sinuses. We can evaluate the frontal and the maxillary by exam. So we can palpate over those, we can transilluminate. I'll show you guys how to do that. Can they breathe? Nasal patency? Nope. So you can check that. You can have them do it themselves. You don't have to hold their nose. So we inspect by otoscope. And so one of the things when you use an otoscope to look into the nose is the septum, right, the middle part of the nose, is really sensitive. And you guys remember the blood flow to the nose, the septum? You guys remember what it's called? Yeah, exactly. And it's really frail, and it's really superficial. So when I jam up an otoscope into the nose, I can cause a nosebleed. But it's also really sensitive, so when you put an otoscope into the nose, be real gentle about it. So what I have someone do is, initially I'll look into the nose by just having them tilt their head back. So I need a volunteer. I get to look in someone's nose. Come on.
Please react up right now.
So,
Macy just wants you to give her some
I want
medicine.
you to do medicine, honestly.
so your otoscope, most of them have a button on them to turn them on. It's on the side or here. But you push that button down and turn it, and it turns your light on. Well, it usually turns your light on. But by turning that, so by pushing that button down and turning it, I turn it on. And by turning the amount, it changes the intensity of the light. So I can have a low light to a stronger light. Okay, so that's the first part of it. This is where I look through, okay? And this magnifies. So it's like a magnifying glass. This is my speculum, right? So if I narrow my vision, I can see it. So you put that on, you just put it on and turn it. So the first thing I want to do is just kind of look visually with my light, so I can kind of look up in there. But I can't see great because it doesn't magnify it. It's not a great look, and it just sees superficial. So you actually want to use your speculum. Now what's going to happen is the longer you do this, the more they're going to blow out their nose and they're going to fog up your viewfinder right here. So, that's just what happens. So the other thing is I don't want to stand here like this, because if I have a kid and they're moving their head, you're going to jab this up their nose. So what I do is I put my hand on their face. So if they move, I control this. But if I'm here and I got this in their nose, it's really uncontrolled. So when I look at their nose, I have to tip back, and then I look through, and I can see all the way up in their nose. So I can see the middle turbinate, okay, really well. I can see the septum. I'm looking for perforations in the septum, looking for colorations. The nose is
a little bit redder than the outside, okay? A real pale blue, boggy, that's allergies. But you look both sides. So again, not here, because think of a kid, but I'm here and I'm looking up and I can really visualize that. And as I kind of go in and need to look, you don't want to jam that in. Okay? That's the nose. Good job. Okay? Throw it away. One of the things you see a lot with your cocaine users is a perforated septum. I've seen that. It's pretty crazy. Like, what? And you always wash your hands, but sorry. You're just gonna have to be mindful.
It's all right.
So how do you document this? Here's some of the terms. You know, I'm looking for crusting blood, deviated septum. Is there swelling? Is there a erythematous look to it? Is there, what kind of drainage we have from the nose? Is there polyps? You guys haven't had this lecture yet, right? So you'll know these terms. It's just on here so you know what to document. Okay, so the frontal sinus, so you palpate. So what you're going to do is you're going to palpate over the frontal sinuses. So when they have infection there, that hurts. Over the maxillary, you just palpate right under the maxillary region. We can also transilluminate the sinus to see if we have a fluid level. But you have to have a dark room, and when you transilluminate, how you do this is, hopefully it shows you. So what you do is, you come to the corner, I'll do it both sides, but you put it right up here, and this illuminates sinuses. Some people have a really big frontal sinus, some don't. You do it both sides, and you're looking for a fluid level. This is really hard to see in this room. If it's dark, you can see it a lot better. So maxillary, okay, what you do is you put this right at the corner of the nose, and you have them open their mouth, okay? And what you're doing is you're looking as it comes through, and you can see a nice, right through the roof of their mouth, unless there's a fluid level, okay? This is a great way, say that right.
I'll just sit down here.
Okay. So, got a picture here. Their light is a little different, but this is the old lights, we don't have them anymore. But they put it right up in the corner there, and then, see, they put it right at the corner, open the mouth, and you'll see that light come through. That's called transillumination. So that test should be no fluid level seen on transillumination. Okay? So we palpate and we transilluminate. Okay.
There should be no light coming through the mouth?
Yeah, there is.
There should be
Yeah,
light?
yeah, because it's air filled. So light goes through air very easily. Doesn't go through fluid as well, right? And you may actually see a different intensity of light when you've got fluid. You actually may see a fluid level. Or there's a big difference between the two. Like you can't see this side, but you can see this side. So that's an abnormal finding of transillumination. The mouth, not the oral, not teeth, okay? We talk about it, we you're fine to stay here. You need to write,
I'm fine, I'm typer. I'm listening, I have it recorded, so it's okay.
because you can go back if you want. You need to type. You're a kinesthetic type learner, you have to do things like learn. Okay. So we talk about dentures, toothache, mouth pain, sore throat, reoccurring infections, tobacco use, right, all that kind of stuff. Hoarseness is a big one. So anyone who has hoarseness that lasts, the smoker especially, you have to always think cancer in your brain. Okay? So someone who didn't have hoarseness and all of a sudden has had hoarseness for a long time, you want to think cancer. Okay? When you find a lesion, they tell you about a lesion, or this is them telling you about a lesion. You want to ask them how long it's been there, has it changed, colors, sizes, have them describe it to you. Does it hurt? Does it work with certain foods? And halitosis, that's bad breath. Okay, so here's the confusion that I want you guys to know about. You okay still? You want to go back on? Make sure you're comfortable. No, you're not. Okay. You all know the uvula. I know you've had anatomy, but people still confuse this. When you're looking in the back of the throat, you want to make sure that you're looking at the anterior pillar and the posterior pillar. I know you've had anatomy, but still people confuse this. Tonsils sit in between the anterior and posterior pillar. And most of us, maybe you guys, but most of us don't have much tonsils as we age. Tonsils shrink up, right? Or they've been removed, so you won't see tonsils at all. But I've seen huge tonsils in 20-year-olds. So look for the tonsils between your anterior and posterior pillar. If you look on your sheet, the OP or oral pharynx, which is, if you look down, oh, now you're going. So the posterior oral pharynx, that's the back of the throat, right back in here. Okay, behind the uvula, that back wall. You can't get a good view of that unless you have them say, ah, because it raises the soft palate, raises the uvula. It also checks a cranial nerve, but you have to have them do that. And patients don't want to do it. Why the heck am I saying, oh, it's stupid, right? But what I tend to say is I'm not doing this just because it really helps me see the back of your throat. And I really need to get to there. And by doing that, it lets me see that. And then they're like, oh, so that's what you're looking for. That's one of the things that I want you to visualize when you look at the back of the throat. Okay, look at the teeth. Okay, look at the buccal mucosa, the inside of the cheek, down along the gums. And you can't do that by having them open their mouth. Can't get to those areas. So you have to use a tongue blade or your hands with gloves on. So you will use you use a tongue blade and actually kind of pull the cheek back. Okay? So make sure you get to all those areas. A lot of times, if I can't do it with this, I'll put a glove on and take my finger and kind of move the cheek so I can see those areas. Or you can use both or one or the other. But get to those areas so you can see it. Because you'll miss cancer without doing that.
Can you see the tonsils without doing that, even though that's more lateral?
The tonsils you can see just as you look straight in. And you really can see them if you have them say ah too, if they're kind of the tongue's in the way. Because as you raise that up, that helps. Because some people have a large tongue, and it's difficult. Okay, make sure you raise the lips, pull it down. Cancers, a lot of time are in those areas. Look at the hard palate. Okay, the soft palate, remember the hard palate's anterior. And then as you go back, you get into the soft palate. Our hard palate's more rugated. When we get into the soft palate, it's definitely smoother. You can feel that with your tongue right now. Check the uvula. You have, say, ah, it should raise equally. That doesn't look equally, but it's just a picture. Okay, so you're checking for your cranial nerves. We're going to go through HENT. We're not going to talk about cranial nerves right now. When we get into the neuro part of phys ed, you're going to learn your cranial nerves. So you'll make sure that I've checked, 2 through 12. Trust me, you'll get it. But definitely do this today because it helps you look at the back of the throat. Keep it in your mind, I'm checking cranial nerves. You also, if you're doing a neuro test, you want to check their gag reflex. And their gag reflex is definitely, if you have their, if you have this in their mouth, right? And I tend to kind of push the tongue down because it's in the way, avoid the last 1/3 of the tongue. Right? Because it triggers your gag reflex. So some people get in there like, so be real sensitive to that because know where that gag reflex is really triggered at. Because I've seen it a million times with students, they're like, I can't sing. So, tonsils look like that, okay? You're looking for exudate. You guys will see this on your ClinMed, but exudative, swollen. Tonsils look like this. They're easy to see compared to the anterior posterior pillar because they're cryptic, okay? So that's a tonsil, that's a tonsil. Here's my anterior pillar, and then the posterior pillar is hard to see because it's covered up with those tonsils. Anterior, posterior, and then the posterior oropharynx. What am I looking for? For the oropharynx, is it red? You know, is it erythematous? Is there cobblestoning? Is there postnasal drainage? Look at the tongue, okay? Checks cranial nerve, but you also want to look at the sides of the tongue. So have them stick their tongue out, move it side to side. Some people that can't take their tongue out, sometimes you actually kind of have to pull the tongue out with gloves and kind of turn it to the side and the other side. You can't see it all. Okay? So cranial nerve 12, definitely moving the tongue. Look underneath the tongue. Most common thing that people forget is to look under the tongue. Okay, you'll see a lot of varicosity, that's normal. It's a velour look to it because of the varicosity there. Looking for swelling, looking for lesions. This is normal things you'll see in the mouth. It's what we call normal variants or normal variant. So when you look at the side of the cheek inside, you'll get a buccal mucosa scar. That's where their teeth come together. This is a big lump on the hard palate, okay? You'll see this. Don't freak out. It's not a tumor. We see this is really common actually. A geographic tongue is also a normal variant. See, they stick their tongue out and it's got a different texture to it all over the tongue. But you ask them, does your tongue always look like that? Yep, it's always looked like that. It's called a geographic tongue. Cortice spots, really common in kids. So you'll see kind of this yellow, kind of whitish, looks like kind of like little pimples inside the mouth. That would be the best explanation to it. But they're raised, and the parents come in and say, what is wrong with my inside of my baby's mouth? And you just tell them this is a normal variant. These are cortice spots. You'll see a uvula that's bifid. That's normal. So how do we document tonsils? Color, and we gotta document size. So this was always a test question. This is a test question. Okay. So if you can see them, okay, and they're not even close to midline between the uvula and the side, they're 1+. If they're just before midline, okay, This is a tonsil sitting right here, that's 1 plus. So here's midline, right? This is 2 plus, right? If they're past midline, right? Three plus, so they're just not quite touching, but they're pretty darn close. Those are 3 plus. So they're getting kind of, they're pretty much touching the uvula. I mean, they're big tonsils. But when they're like touching each other, those tonsils are like that. You can't even see the uvula a lot of the times. It's kind of squished up underneath there. That's 4 plus tonsils. Those are big tonsils. Okay?
So if the uvula is bifid, since that may be, a common finding, would you adjust for 3 plus?
You're still pretty much going to say, if those tonsils touch both of the uvulas, I guess,
Yeah.
you'd still say it's 3 plus, unless they're completely, if they're like this, then I would say, this is only 2 plus, because it's only coming halfway here. But if you're coming here and here, I'd say they're 3 plus. You can adjust it, yes. Really, it's kind of right before midline, past midline, and touching is another way to think about it.
Does it have any clinical significance of it being dangerous if
Yes.
it's touching each other?
Uh-huh. So you document this as tonsils as 4 plus, and because I'm going to document it, especially if I have an infectious process going on. This may be non-infectious, okay, to start with. So if I have an infectious process going on and I want them to come back in, I can document decrease in size. The other thing is I a lot of times have kids, even at this age, you guys, some of you, 20-year-olds who describe apneic episodes, so sleep apnea. And one of the things that will cause that is enlarged tonsils. And so if I send, or they snoring, really bad snoring, my partner says, snore like that. So I'll look and see their tonsils, and so when I send them to the EENT, right, or the ORL, that's one of the first steps we have to do if they have big tonsils. So I'll say 4 plus tonsils, describe snoring, and partner hears apneic episodes. Because they'll need a sleep study, but insurance tends to want to deal with that because that may be the cause. Because they don't like to pay for a sleep study initially. If we have a physical cause, which may be the tonsils. Usually it's the obesity, central obesity that causes apnea. Or white females with a real short jaw, like me. That's another, maybe be a thin female with a short jaw that causes apnea, not central obesity. Those are 2 big causes of sleep apnea. Okay, ears. Ringing in the ears, tinnitus, right? It's ringing in the ears. Vertigo, earaches, discharge. So if someone comes in with ear pain, I want to know if they have discharge from the ear. Helps me tell if it's a swimmer's ear versus a middle ear infection. Always look at the ear. There's some normal things that we can see. So look at the external ear. If you learned something from me today, not yesterday, because I had some things yesterday, but today, I want you to always look at behind the ear, into the mastoid area. Because people will look at the ear when kids come in, and they'll look inside the ear, but they forget this part, and mastoiditis is a big deal. And you can see it sometimes because you get redness back here, but you can also palpate in that area and get mastoiditis. Because it's more common than you think. We don't have mastoiditis because we're Americans and we put every kid who has an ear infection on antibiotics, which we shouldn't. But we still get mastoiditis. So don't just look at the ear, look behind the ear, okay? That's your lesson for the day. I don't want you to miss that, because they go on IV antibiotics they go to surgery and they go to IV antibiotics. It's a big deal, it's an emergency. Okay? So look down the canal, look for discharge, look for things. Palpate the ear, okay? And it not only, again, palpate back here, but is the ear move? If I do this, does it hurt? Okay? So that's a classic movement of someone who has ear pain. If I have swimmer's ear, you guys know what swimmer's ear is, right? This is diagnostic for it. It's like, oh, well, they have swimmer's ear, because that hurts. Because I've moved the canal where the infection is, and it irritates it. It's actually pretty painful. So always tug on the ear. So auricular sinus, that's a normal thing, okay, that can be there. The Dorman's tubercle is a bit normal. We see this in people with trauma to the ears, common in wrestlers. So what happens is there's not really great blood flow to the ears, and it's a lot of cartilage and skin. And so if they get trauma to it, they rupture the blood vessels and they separate the skin from the cartilage. And so what ends up happening is they lose the blood supply to the cartilage. And if you don't drain that right away, they build up scar tissue between the skin and the cartilage. And so this is a permanent thing. So what you can do with a wrestler or somebody who comes in with this initially swollen, like the one on your right, is they can drain that and compress it to try to get the skin against the cartilage, and so that it won't scar down like the picture on your left. So you can't actually prevent these, but it's really, no.
Doesn't have to get really sick, no?
Yeah, really quick. Okay, so we definitely want to check their hearing. So the test that you're gonna, this is another thing you need to know. There's a lot of ways to test different things that we're gonna talk about. So you could Google auditory acuity and you'll hear the watch test, you'll hear the whisper test, but we're gonna do the finger rub test. So if you're out on a rotation, they say, oh, Joe, check this, and you say this, they say, well, that's not what I do. Don't be upset. There's different ways to do different tests, okay? First of all. So what I want you to do for auditory acuity is, I want you to have the patient close their eyes, okay? And then I want you to rub your fingers together, and then I want you to have them either just like raise their hand or say right or left ear, okay? So close your eyes, and just raise your hand or tell me right or left ear. So, and I say, don't right or left, or raise your hand, because some people don't know they're right or left. Kids, right? Me. And you want them to close their eyes. You can stand behind them, but it's difficult if they're sitting on the exam table, so it doesn't matter to you. Okay, so here's the Weber and the Rene. Weber and the Rene. This, we're going to decide if the hearing loss, if they have hearing loss, if they describe hearing loss, if this is a sensory neuro or a conduction. This is really difficult to get, and I'm going to try to, did you guys learn this in physiology yet? Okay, I'm going to try to explain this so you get it, and you'll always remember it. Maybe. Okay. Conduction. Okay, conduction. I guess I gotta have some light, right? Playing in the dark.
A quick question about the previous auditory
No.
acuity,
No,
please.
come on. Okay, yeah, go ahead.
What's the intensity of which you need to rub your fingers with?
Just not hard, just normal. Like you're. It does, just open that. Just rub it.
Took you a long time.
You should hear this.
Thank you.
You're welcome. So, the ear. I'm not a great drawer, so bear with me.
Or erase it.
Okay, so you have this head. And you have the canal of the ear, right, here's the ear. You have the canal, and then you have the middle ear, which is the tympanic membrane and your ossicles, right? Because of the ossicles. So then, we're gonna talk about mainly the cochlear apparatus, right? That sends a signal to the brain. This is dumbed down. The ossicles send a signal to the cochlear apparatus, right? And then it sends to your brain, and then you go, oh, I can hear. You can have two problems. You can have a conduction problem, meaning that sound can't come through the canal, or it's in the middle ear. So, can't come through the canal because I have a bunch of wax. Or I have an otitis externa, okay? Or, in my middle ear, I have an ear infection because my tympanic membrane can't vibrate. Or I have just fluid in there. I'm an allergy person, I got a lot of fluid. Okay? That's a conduction problem. That's conduction hearing loss. If I have a problem past that point, there's the cochlear's damaged or the nerve's damaged or something, that's sensory neural loss, hearing loss, right? So keep that in mind. Does that make sense? Okay. If someone comes in complaining of hearing loss, I want to know which one it is. So we do two tests. You have to have two tests to help figure this out. One is the Renee and one is the Weber. If I do the Weber, what I do is I hit this tuning fork and it vibrates and it makes a sound, right? Because people sing to this. Okay? You put it on the top of their head and they'll hear it in both ears. They'll hear the vibration and they'll actually hear sound. If they have no hearing problems, it'll be heard equally in both ears. They'll say, I hear it equally. So, right, you've heard it in both ears, right, equally, unless you have hearing problems. Right? You hear this equally? Pretend you did, yeah. Okay. So, let's go to the next slide. Okay. If I have a sensory problem, okay? So I can't hear here, right? I can't, this isn't working. Where am I going to hear it?
Top of your head.
The other is.
In one ear.
Right. So if I can't hear on this side, if I have sensory I'm damaged here, it's going to lateralize, so this is a person looking at me. Here's right, here's left. It's going to lateralize to the bad ear. Because this works. It can hear. It can interpret. So it lateralizes to the good ear. You hear the works, okay? Because this can't work at all. It doesn't work. So if even sound came in here from the air, it doesn't work. Okay?
So it goes to the good ear, right?
Goes to the good ear. So what they're gonna say is, you don't know if it's a good ear. They're just gonna say, I hear it greater in my left ear. And you go, oh, okay, so I have that. I don't know if this is sensory loss. I don't know anything at this point. They're just gonna say it lateralizes to the left ear. So you know something's going on at this point. Okay? So you're right. Weber lateralizes to the left ear. Okay. Now, if I have a conduction problem, let's say I've got wax here. It's pretty common. I do this test. This works. Okay, I can hear, and I can hear here. This is what happens. It can sense both, okay? But sound coming in my ear canal here, it's more stimulus that I need. So it's confusing it. So it'll lateralize to this side. Right? It intensifies, the sound will intensify to that side. Because I also have you talking or air conditioner running, and so it'll lateralize to this side. It'll lateralize to the side that has a conduction hearing loss side. So if they have an otitis media or wax in the side, you put this on here, they'll hear it on that side. Okay?
By lateralization, do you mean like intensify, like?
Lateralize is, it lateralizes, meaning lateral. So it's how you write the test. I'm using that term, that's how you write it on a chart. So lateralizes right, lateral left. Because if it stays here, it doesn't, the Weber test does not lateralize. It lateralizes to the side, right? Lateral, I go to the lateral. I know. You just know if it goes right or left. You don't know what's going on. I know, it's confusing, but you're going to get it.
Just for clarification, so conduction hearing, what ear can you not hear in over there, or can you hear equally?
You don't know, but you don't know what's going on. Someone comes in and says, I don't feel like I can hear. First test you do is this. And you say, lateralizes to the right. Okay? I don't know if they have conduction hearing in the right, or I don't know if they have sensory neuro hearing in the left. Right? Because that's the possibility right now. That's my option. That is my option. It gets more, there's way more to it because you get it both, but that's what I want you to know. If I do this test and if it lateralizes to my left, I either have bone conduction or sensory neural loss in the other side. But I don't know this yet, right? How do I know this? I don't know. So we do another test to figure it out. Ready? Set. This is a test question, that's why I'm going this. Okay? So the next thing we go to is the Renee. Okay? We can always hear better in air than we can hear through bone. Always. If you have good ears. So, what we do is we put this on the mastoid process, and you tell the patient to tell you when they can't hear it anymore. Okay? And I can't hear it anymore. Then I go, it's much more intense. And I kind of count how long it takes for me to quit hearing it in this ear. and a K. Much longer, usually about 2 times as long. Okay? So, normal. I need to see this. Air conduction. This word conduction has nothing to do with conduction problem. Please understand that. It's just the wording they use and it's confusing. Air conduction is greater than bone conduction. You have nothing to do with hearing loss, conduction hearing loss. Nothing. It's just the term they use. Air conduction, bone conduction. Okay? Make sense? That's normal. Okay, so I put my tuning fork right over the mastoid process right here. What am I testing? I'm testing.
The vestibular.
I'm testing sensory neuron. Because I'm not putting sound here. I'm conducting it through the bone into the sensory neuron. This is where people get this, they always get this confused. Okay?
They said bone connection, or conduction.
So you put-
Oh, bone conduction, I'm sorry, yes.
It is
You're
bone.
checking bone conduction to check neurosensory.
Okay.
Sorry. I didn't mean to confuse you. That is correct. Okay? If I put it here, I'm checking conduction. Is the sound going through the canal and into the cochlear system? Okay? So, if my bone conduction is greater than my air conduction, what's the problem?
No, that's the conduction or something.
Yes. You have conduction hearing loss. I know, it's confusing. It's confusing, but you just gotta think of it this way.
What was that one that is right there, the tuning fork being in the middle of the canal? What did that?
This is on the mastoid process.
Why not? Or why did you? It goes right there.
What's AC again?
You have to put it behind, because otherwise
Air
if it's
conduction.
weird, it's.
So that's where it's sitting right here. Okay?
I know, right out.
So if I stick that tuning fork on my mastoid process, I am testing for sensory neuron. That's what I'm evaluating as my sensory neuron. That's what I'm checking for. And what I'm definitely making sure is it's a ratio. I want to definitely make sure that this is half or at least less than here. So if all of a sudden, my air conduction is not very much, I know that the signal's not coming through here. And so definitely, there's no conduction, there's a problem with my conduction.
Why do you need to do the Weber in addition to this?
Because if you don't, how do you know what's going on? Because watch this. If I have, this is conduction hearing loss, right? Conduction hearing loss, right? So conduction hearing loss. If I have sensory neuron hearing loss on this side, this is what you have. So you have to put them together.
But wasn't that normal though? When the
It's
air
normal.
condition is greater than the bone?
But that's why you do the Weber test.
That's why you put the Weber with
Because
it.
if you don't have
So,
an abnormal Weber test, you're not gonna have sensory.
so, if we put, it lateralizes to the, let's do the right, because that's what we're looking at. Okay, it lateralizes to the left. Left, right. What do we want to do? What do you guys want to do? So you're not.
Let's just do it.
To the left. To the left side of the box.
To the left. Okay, so it lateralizes to the left. So it lateralizes to the left. We either have sensory in the
Right.
right, or
Connection in the left.
conduction in the left. So how do we test this? We do the right. So how do we figure that out?
Do the bone one.
We do it, okay? So what if the bone conduction, well, let's just do it here so we can figure it out. So let's say that bone conduction is greater in the right, left. Bone, did I say left?
Yeah, she said the bone was greater in the left.
So
you're
you're
saying
saying
the
the
left.
bone is greater than the air, correct?
Which means that there's a conduction in the left.
Right? And then we have this. And that's exactly.
There's nothing wrong.
Then you have sensory.
That's not left, right?
Because your air, no, that would make it sensory.
Right, your left ear's small, your right
Your
ear
left
is
ear is
sensory.
normal,
Yeah.
right? It is sensory for the right
Do it.
Well, if it lateralizes when there is something wrong, there's nothing wrong with it lateralizing.
This here, this is bone. Did I just get myself confused? No, this is conduction here.
Yeah.
So you have, so I have something in my conduction here. This is normal.
If you started with the Renee test and you tested both ears and you had BC greater than AC, do you have to do the Weber test?
In just one ear or both?
Oh, just one ear.
No, you wouldn't have to.
So do you usually start with the Renee or do you always do them both?
I usually start with the left.
So we start, so that,
Because if it doesn't lateralize, I don't have a problem at all.
Does that, so if you have the AC is greater than the BC, there's still hearing loss because it's lateralized.
If you do the Renee,
Yeah.
there's
Right here.
that's
No, the other
lost
one.
Yeah,
somewhere.
oh, wouldn't that be
It's
sensory in the right
Not
ear?
always. If you just did
If there's
Renee
a lot
and
No,
it's
like if you do
Yeah.
the, if you do
It's
the Weber and it
not
lateralizes to the left.
It's not normal.
Okay, this is what this is about.
And you
Oh, yeah,
get
lots of
basically
lateralized.
BC,
So if you're,
that's
if
you
it
have substance
lateralized,
there,
then yes,
right?
that would be sensory neural, but
That wouldn't be
if it's
normal.
lateralized, that would be normal.
Yeah.
Sensory neuro.
If the Weber lateralizes, that
I think
means
she was a conductor.
I know what you're talking about.
They just got even.
that's sensory neurological.
Yeah, but I think she
That's why.
was.
So you have to say there's no
It's just 2 to 1,
lateralization,
doesn't
then
it?
that would be normal.
Well, it did.
But she just said that was
lateralize.
normal.
It lateralized to the left.
How do you, she's not saying that?
No, I think she's saying the conduction is one of the places.
Can you explain the example of both ears? You probably know.